Welcome to Optic Surgeon, the ophthalmology podcast.
Great to be here.
Today, we're really zeroing in on something you'll see all the time, especially as residents or final year MBBS students. Eyelid swelling. We want to give you a clear, sort of actionable way to approach these cases.
Exactly. You see a lot of it. And knowing how to sort through the possibilities quickly, that's really key.
Okay, so let's paint a picture. Imagine a patient walks in, one eyelid suddenly puffy. It's red, maybe a bit sore.
Yep.
What's the immediate thought process? Like, is it an infection? Is it maybe an allergy? Or, could it be something worse?
Right. That initial sorting is crucial. Let's keep that kind of scenario in mind as we talk through this.
Perfect. So maybe some key facts first. Eyelid swelling or edema. It can be one eye, can be both.
And you often see other things with it. Redness, maybe the lid feels warm. It could be tender or painful.
Or itchy. Sometimes discharge, too.
Exactly. Itching, discharge, all possible. And one of the first things to ask is, how quickly did this happen? Was it sudden, like overnight?
Acute onset.
Right, acute. Or has it been creeping up slowly, more of a chronic thing? That timeline, plus those other symptoms we mentioned, really starts to narrow things down.
Okay, let's dive into the causes then. Big category first. Inflammatory conditions.
Blepharitis is super common. That's inflammation right at the lid margin.
You mean like where the lashes are?
Precisely. You might see scaling, crusting, bit of swelling. It can be anterior, right at the lash line, or posterior, involving those oil glands, the meibomian glands.
Okay. And that's usually more of a chronic grumbling thing, right?
Often, yes. Recurrent irritation. Now, if it's more acute, a distinct lump. You think of hordeolum, a sty.
Ah, the sty. Everyone knows that one.
Yeah, it's a localized infection. Either the glands of Zeiss on the outside or meibomian gland inside. It's usually pretty tender, red bump.
Got it. And then there's the chalazion. Similar spot, but different.
Right. A chalazion is more chronic. It's inflammation of a meibomian gland again, but it's granulomatous, usually painless. Presents as this firm little nodule in the lid.
So less angry looking than a sty, typically.
Generally, yes. Less acute inflammation, less pain often. Now, if the whole lid is really swollen, red, warm, tender, we have to think about cellulitis.
Okay, cellulitis.
Yeah.
2 types here, right?
Crucially, yes. First is preseptal cellulitis. That's infection in front of the orbital septum, that fibrous sheet in the eyelid.
And the key thing here is?
Key thing, eye movement is normal, no pain with movement, and the eye itself isn't bulging forward, no proptosis. Vision's usually fine too.
Okay, so preseptal is contained to the lid tissues.
Exactly. But
Stop.
if you do see proptosis, if eye movements are restricted or painful, if vision is down, maybe the patient feels unwell, has a fever.
Then you're worried about orbital cellulitis.
That's the one. Infection behind the septum. That is an ophthalmologic emergency.
Yeah.
Needs urgent attention.
We'll definitely come back to that distinction. What else causes inflammation? Allergies?
Oh, absolutely. Allergic reactions are common culprits. Think contact dermatitis, maybe new makeup, eye drops, plants.
Causes quite dramatic swelling sometimes.
Can do. Significant swelling, often really itchy. You might also see the conjunctiva swell up. That's chemosis.
Okay. Moving on to infections specifically, beyond styes and cellulitis.
Well, don't forget viruses. Herpes simplex or herpes zoster shingles.
How would that look different?
You're looking for vesicles, little blisters on the eyelid skin. And often there's a history, maybe previous cold sores or shingles or recurrent eye issues on that side.
Right, these vesicles are a big clue.
Huge clue. Now, systemic conditions. Usually not the primary cause of just eyelid swelling, but they can play a role.
Like what?
Well, things like rheumatoid arthritis or lupus, they cause general inflammation, while they more typically cause dry eye, scleritis, things like that.
Your overall inflammation could potentially contribute to some lid edema sometimes?
Potentially, yes. It's usually part of a bigger picture, though.
And trauma, obviously. Get hit in the eye.
Yeah, direct trauma, pretty straightforward, causes swelling, bruising. The big thing with trauma is always consider if the globe itself might be injured, an open globe.
Right. Need to be careful not to press on the eye if you suspect that.
Absolutely. And then there are, less common things.
Yeah.
Cysts like acrin hydrocystomas, sweat gland cysts.
Fatty fluid bumps.
Yeah. And very rarely a tumor, like basal cell carcinoma, the most common malignant one. Usually a slow-growing lump, pearly edges, but it could have some associated swelling.
So, quite a list. Which brings us to the workup. Patients there, swollen eyelid, what's the process?
History, it's paramount.
Okay, what are the key questions?
When did it start? How long? Getting worse? Better? Any pain, itching, discharge, vision changes, crucial.
And past history.
Any previous eye problems, any medical conditions, especially things like diabetes or autoimmune disease, allergies, food, medication, environmental. What meds are they on, including over-the-counter stuff and eye drops?
And specifically ask about trauma or exposure, right? New soap, makeup, being out in the garden.
Exactly. You need to actively ask about potential triggers. That history really guides your exam.
So the examination itself, what are the steps?
Okay, first, check vision. Visual acuity in each eye. Document it. Then, a really careful external look.
Inspecting the lids.
Right. Redness, the amount and location of swelling. Does it feel warm? Is it tender to touch? Look closely for any lesions, vesicles, crusts, nodules, ulcers. Gently palpate. Feel for any lumps or fluctuants, that bulgy feeling suggesting pus.
Okay. Then pupils.
Check the pupils, reactions to light,
Yep.
and specifically look for an RAPD, a relative afferent pupillary defect.
Why is that so important here?
An RAPD suggests the optic nerve isn't working properly.
Right.
That's a big red flag for orbital involvement, like in orbital cellulitis.
Got it. Next.
Eye movements. Check the extraocular muscles. Can they move the eyes fully in all directions? Is there any pain when they do?
Again, looking for signs of orbital involvement.
Exactly. Restriction or pain on movement points towards something happening behind the septum.
Yeah.
Then you need the slit lamp.
For the anterior segment.
Yep. Look at the conjunctiva. Is it red, injected? Is it swollen? Chemosis. Check the cornea. Any staining with fluorescein, any white spots or infiltrates suggesting infection. Look in the anterior chamber for cells or flare. Signs of intraocular inflammation.
And one last check.
Quick feel of the preocular lymph nodes just in front of the ears. If they're swollen and tender, it adds weight to an infectious cause.
Okay, thorough workup leads you to a likely cause. Now, management obviously depends on the cause, right?
Entirely. So let's run through them. Blepharitis.
Lid hygiene, right. Warm compresses, scrubbing the margins.
That's the mainstay. Warm compresses, gentle cleaning. Often add a topical antibiotic ointment like erythromycin or bacitracin, especially if it looks infected. Sometimes, for posterior or stubborn cases, oral doxycycline might be needed.
Okay, hordeolum, the sty.
Warm compresses, lots of them. That's number one. Helps it drain. Topical antibiotics maybe, but the heat is key. If it doesn't resolve or it gets really big in points, might need a little incision and drainage.
Chalazium. Similar start.
Similar start, warm compresses, but they can be persistent. If it hangs around and bothers the patient, options are incision and curettage, scraping it out, or a steroid injection into the lesion.
Right. Now, the cellulitis types.
Preseptal?
Preseptal cellulitis usually responds well to oral antibiotics. Need good coverage for skin bacteria. But you have to monitor closely.
To make sure it doesn't become
Orbital cellulitis, exactly. If there's any sign of progression, worsening swelling, pain, vision changes, proptosis, they need reassessment immediately.
And orbital cellulitis itself.
That's admission. IV antibiotics, broad spectrum, urgent imaging, usually a CT scan of the orbits to see how bad it is. Look for an abscess.
Might need surgery too.
Potentially, yes. If there's an abscess, it often needs surgical drainage. This is a team effort, usually involving ophthalmology and maybe ENT or infectious disease specialists.
Okay. What about allergic reactions?
Avoid the trigger if you can identify it. Cold compresses can feel good.
Yeah.
Then antihistamines, topical drops, or oral pills, maybe a short course of topical steroids to calm the inflammation and itching. And the herpetic ones, if you see those vesicles.
Antivirals are key, usually oral aciclovir, valaciclovir, or famciclovir. If the cornea is involved, you might add topical antiviral drops too.
Trauma management.
Simple contusion. Cold compresses initially for swelling, then switch to warm compresses after a day or two. But the main thing is making sure there's no other ocular injury. Rule out globe rupture, hyphema, retinal detachment, etc.
And those other causes, cysts, tumors.
That's very specific. Cysts might be observed or excised if problematic. Suspected tumors need biopsy and appropriate management based on the pathology, often surgical excision.
One more point on management corneal involvement. If you suspect infection there.
Yes. Infectious keratitis. If you see a corneal infiltrate, especially with staining, you worry about bacterial superinfection, maybe fungal or acanthamoeba less commonly. Cultures might be needed, especially if it's severe or not responding.
And patching.
Important point. If you suspect infection or the cornea is thin, avoid pressure patching. Use a clear plastic shield for protection instead. Pressure patching can make bacterial infections worse.
Okay, that covers a lot of ground. So, let's boil down. High-yield pearl time. What's the one thing residents really need to nail?
It has to be differentiating preseptal from orbital cellulitis. It's probably the most critical decision point in managing acute eyelid swelling.
Because the management and prognosis are so different.
Hugely different. Preseptal is usually outpatient, oral antibiotics. Orbital is an inpatient emergency, IV antibiotics, potential surgery, risk of vision loss, even intracranial spread.
So what are those absolute red flags again, the ones that scream orbital?
Proptosis, the eye bulging forward. Restricted eye movements, especially if they're painful. Decreased vision, and possibly an RAPD. Any of those should trigger immediate concern for orbital cellulitis.
And if you have that concern,
Don't wait. Get imaging, usually a CT scan, and get the patient seen by ophthalmology urgently. Better to image and be wrong than to miss orbital cellulitis.
absolutely crucial point. Don't delay if those red flags are present.
Cannot emphasize that enough.
So hopefully this deep dive gives you a solid framework. When that patient with the swollen eyelid comes in, you'll have a systematic way to think through it.
Yeah, from the history and key facts, through the common and not so common causes, the essential exam steps, and the management pathways.
And always keeping that preseptal versus orbital distinction front of mind.
Exactly.
Okay, that's a wrap on our deep dive into eyelid swelling. Stay focused, keep learning, subscribe.